So good morning. Today topic of discussion is paraneoplastic syndrome in lung cancer. So paraneoplastic syndrome is a heterogeneous group of disorders associated with cancer, but not due to direct invasion, obstruction, or metastasis. So it was usually seen in 8 to 10% of patients with lung cancer, and it caused by the aberrant release of humoral mediator such as hormone-like peptide, cytokines, and autoantibodies. Basically, if we see the spectrum of paraneoplastic syndrome, it involves multiple domains. One is neurologic syndrome, endocrine, hematologic manifestation, dermatologic, rheumatologic, and ophthalmologic paraneoplastic syndrome. So, to start with, we will discuss about the paraneoplastic endocrine syndrome. So, the most common paraneoplastic endocrine syndrome is hypercalcemia of malignancy, which is also known as humoral hypercalcemia of malignancy. It is most commonly seen in small cell lung cancer, and it is caused due to parathyroid hormone like peptide release. And second most common is SIDH, which is syndrome of inappropriate antidiuretic hormone syndrome, and it is most commonly seen in small cell cancer, and it is caused due to ectopic ADH secretion. And less common syndrome are Cushing syndrome, acromegaly, Carcinoid syndrome, gynecomastia, and non-isolated isolated cell tumor hypoglycemia, which can be caused by exogenous or ectopic hormonal secretion. So we'll start with the most common condition, which is humoral hypercalcemia of malignancy. So it is reported in 2 to 6% of lung cancer at the time of initial diagnosis, but incidence increases to 8 to 12% over the disease course. So it is most commonly seen in breast, renal, multiple myeloma, lymphoma, and lung cancer. So if we see the hypercalcemia in malignancy, it caused due to multiple factors. It can be PTH related peptide release or GCSF granulocyte colony stimulating factor release, which can cause to local osteolytic hypercalcemia, or rarely it can cause due to parathyroid hormone production and 125 dihydroxy vitamin D release in lymphoma. This thing can rarely cause also hypercalcemia, and it is usually associated with advanced disease and poor prognosis. And if we talk about this parathyroid hormone like peptide release, so it is known as humoral hypercalcemia malignancy, which is a most common cause of hypercalcemia in malignancy. And if we go to the clinical feature of hypercalcemia malignancy, it is same as the hypercalcemia. Most common side effect is the GI side effect, which is nausea, vomiting, and abdominal pain and constipation. And neuropsychiatric side effect can be seen like fatigue, lethargy, mood change, and cognitive dysfunction. And renal side effect is due to polyuria, and due to polyuria and hypercalcemia, nephrolithiasis and nephrogenic diabetes insipidus can be seen. And cardiogenic side effects are like arrhythmia, short QT, interval, and this can be remembered like with mnemonics of stones, bones, and abdominal moans and psychic groans. So to diagnose humoral hypercalcemia malignancy, patients should have underlying malignancy or occult malignancy with calcium more than 10, total calcium more than 10.5 milligram per deciliter, or ionized calcium more than 5.6 milligram per deciliter. And basically, it was categorized into mild hypercalcemia, moderate, and severe hypercalcemia according to the range of calcium level inside the body. And usually treatment depends on the severity of the hypercalcemia. Mild hypercalcemia and asymptomatic moderate hypercalcemia, we need not to do anything actively. We just have to avoid the supplement which can cause hypercalcemia. And those patients with 10 milligram deciliter of calcium, total calcium, and those who are symptomatic, or more than 14 milligram deciliter of calcium plus or minus symptoms, this patient we need to treat. And the first line treatment is the forced dialysis. It is IV fluid of around 2 to 4 liter per day followed by loop diuretic 20 to 40 mg we have to administer for this patient. And those patients not responding to the forced dialysis, we can go ahead with the bisphosphonate, which is famotidine, zoledronate, or denosumab, which is a monoclonal antibody against the rank ligand. So these are the first line treatment for the humoral hypercalcemia of malignancy. And second line treatment are the calcitonin, mitramycin, and gallium nitrate, and sometimes corticosteroid, which can be used, but these are of less clinical significance, usually associated with more toxicity. And second most common endocrinopathy, paraneoplastic endocrinopathy, is SIADH. So it is a state of euvolemic hyposmolar hyponatremia secondary to ectopic ADH production, and usually associated with small cell cancer. As you know, hypercalcemia is more associated with squamous cell. It is more associated with small cell cancer, and non-small cell cancer comprises of less than 1% of SIADH in the malignant population. And the diagnostic feature of SIADH, which was put forward by Swartz et al. In 1967, is there should be hyponatremia, or sodium should be less or equal to 135 milliequivalent per liter, and it should associate with low serum osmolarity, less than 275 milliosmol per kg of water, and patient should be in euvolemic state, and urine osmolarity should be more than 100 milliosmol, and urinary sodium excretion should be more than 40 millimole with normal dietary sodium uptake, and there should be no other endocrinopathy, like there should be a thyroid function, adrenal function should be normal, and it should exclude renal failure. These are the major diagnostic feature of SIADH, along with supplemental feature like plasma uric acid less than 4 milligram per deciliter, even less than 10 milligram of deciliter, and correction of hyponatremia through fluid restriction, those who are responding, coming under the minor criteria, which can also give indication that patient is having SIADH. So to see the cause of SIADH, it is not only seen in case of malignancy, it can be seen apart from malignancy in the pulmonary infection like abscess, pneumonia, TB, aspergillosis, and cystic fibrosis, and in CNS involvement like CNS abscess, meningitis, CNS AIDS, and bleed, cerebrovascular accident, trauma, and multiple sclerosis, Guillain-Barré syndrome, and Side-Drager syndrome. This can also associate with SIADH. And drug like desmopressin, oxytocin, vasopressin, SSRI, anti-epileptic, it can promote antidiuretic hormone release, so it can cause also SIADH. And the other rare causes are like hereditary and idiopathic. If we come to the malignancy, so lung malignancy is the major contributor of the SIADH. Small cell is more than the mesothelioma, followed by stomach, pancreas, bladder, endometrium cancer, and rarely it can be seen with prostate, thymoma, leukemia, and lymphoma. So if we go ahead with the treatment of SIADH, so first thing we have to know that sign and symptoms usually depends on the degree of hyponatremia and rate of decline. Slow decline, usually patients are asymptomatic, and those who are having symptoms are non-specific, such as anorexia, nausea, vomiting, irritability, headache, and abdominal cramp. So, but those patients, those who have rapid decline in the sodium, usually present with severe symptoms. Sodium less than 120 milliequivalent per liter usually develop cerebral edema. So they usually present with headache, irritability, restlessness, hyporeflexia, confusion, coma, seizure, brainstem herniation. Finally, they can lead to death. So usually we should intervene patient with those who are in rapid decline, or those who are of sodium less than 120 milliequivalent per liter. So we should the treatment of SIADH is water restriction, and those patients who are having sodium less than 120 milliequivalent, we have to correct the sodium level by 3% saline. But there is risk of if we are correcting it rapidly, then there is the risk of osmotic demyelination. So we have to keep the target of 8 to 12 of milliequivalent per day of correction. So other modality which we can use for SIADH are we can give patient diuretics along with oral salt, so that it will lose the free water and retain the sodium. And apart from this modality, newer generation like 12-haptan, conivaptan, we can use in patient of SIADH. These are the aquaretics, means it act on aquaporin and releases the free water. Usually it help in case of SIADH with significant fluid retention, but it is also associated with more risk of osmotic demyelination. So use of these baptans usually require regular monitoring of the sodium. So next is the ectopic Cushing syndrome. It is most commonly seen in case of small cell lung cancer, 30%, and less commonly it is seen in bronchial carcinoid. So diagnostic criteria for ectopic Cushing syndrome is there should be patient should have hypocortisolism, which can be determined by the raised late night salivary cortisol or raised 24-hour urinary cortisol level, negative low dose dexamethasone suppression test. And this hypocortisolism should not due to iatrogenic hypercortisolism. So there should be exclusion of iatrogenic hypercortisolism. And elevated morning ACTs should be there, but this ACTs can be due to pituitary or non-pituitary origin. So we have to rule out pituitary origin also. So there should be absence of pituitary tumor on imaging. It can be done with CT or MRI. And negative high dose dexamethasone suppression test, it 100%. It usually rule out pituitary origin malignancy to the extent of 100%. So it is only positive in case of pituitary tumor. So negative high dose dexamethasone suppression test is the diagnostic test for the ectopic Cushing syndrome. So the treatment of ectopic Cushing syndrome is the primary ideal treatment is surgical excision, and drugs like ketoconazole and metarapone can be used to decrease the cortisol synthesis. So as we all know, all this paraneoplastic syndrome, primary treatment should be the management of the malignancy rather than the treating the syndrome. So next is the hematological paraneoplastic syndrome. This can be granulocytosis or thrombocytosis or thromboembolism. And usually this granulocytosis and thrombocytosis are more commonly seen in non-small cell cancer and associated due to the mediator of colony stimulating factor like granulocyte colony stimulating factor and granulocyte monocyte colony stimulating factor, and other factor which is associated with this interleukin 6. And the most commonly seen syndrome is the thromboembolism in the malignancy. It is most commonly seen in non-small cell. Eventually can be found also in some patient with small cell cancer, and it is mediated by the tissue factor and cancer procoagulant. So if we go ahead with this venous thromboembolism associated with malignancy, non-small cell lung cancer is more commonly seen with rather than the small cell, and adenocarcinoma is the more common than the squamous cell carcinoma. So according to ECS guideline, treatment with subcutaneous low molecular weight heparin should be considered for the first 6 months over the vitamin K antagonist, and extended anticoagulation beyond first 6 months should be considered for an indefinite period or until cancer is cured. And newer molecules like direct oral anticoagulants like endoxaban and rivaroxaban can be used as alternate to low molecular weight heparin in patients with low risk of bleeding and no drug-to-drug interaction. And low molecular weight heparin for those having high risk of bleeding and thrombocytopenia. And this vitamin K antagonist like warfarin is reserved for the patient those who are contraindicated for this LMWH, and newer molecules like endoxaban, rivaroxaban, or those who are not affordable to the low molecular weight heparin or endoxaban. So this is one of the most common paraneoplastic syndrome usually encountered in our day-to-day life. And other paraneoplastic syndrome is neurologic paraneoplastic syndrome. It is mostly caused due to onconeuronal antibodies. All of paraneoplastic syndrome, which we already discussed, either they caused by some humoral mediator, but this is the syndrome usually caused by the autoantibodies. So most common syndromes are encephalomyelitis and limbic encephalitis, subacute sensory neuropathy. These are all most commonly seen in small cell malignancy. So it is associated with anti-HU antibody, and paraneoplastic cerebellar degeneration is seen in patient those who have autoantibody against anti-HU, anti-UO, anti-GAD, anti-JIG4 autoantibody. And the less common syndrome are osteoclonus myoclonus, which is associated with anti-RI antibody. And cancer-induced retinopathy is mostly seen with patients with anti-recoverin antibody. And these are the central nervous system. This syndrome usually involves the CNS, but Lambert-Eaton syndrome is usually involves the peripheral nervous system, which is caused by the anti-PQ calcium channel or voltage-gated calcium channel. And Steve-Person syndrome is rarely seen in case of small cell malignancy, which is caused due to anti-amphiphysin and anti-GAD antibody. So all these neurologic paraneoplastic syndrome can be a first presentation to a patient with some occult malignancy. So whenever a patient come in an older age group with new neurological symptoms of subacute origin, we should clinically suspect a paraneoplastic neurologic syndrome. So what are the clinical features we can appreciate in this patient is new onset sensory loss, which can be caused due to involvement of spinal cord or dorsal root ganglia. Behavioral loss, memory loss, or new onset seizure can be due to involvement of limbic system. Nystagmus or dysarthria can be caused due to the brainstem involvement. Involuntary eye movement like gaze disorder can be seen in case of involvement of dentate nucleus. And autonomic dysfunction and proximal muscle weakness usually seen due to the nocturnal and neuromuscular junction involvement. And photosensitivity and visual field scotoma is usually seen whenever there is a photoreceptor involvement in this anti-recoverin antibody involvement. So if this patient came with subacute presentation of all this symptomatology in an elderly age group, so we should not, before going for any other cause, we have to rule out any paraneoplastic manifestation. So we have to look for any occult malignancy in lungs or other system according to their incidence. So treatment of this paraneoplastic syndrome usually treatment of the primary usually resolve this paraneoplastic neurologic syndrome, but there are multiple clinical trials which also involve IV immunoglobulin plasmapheresis along with the primary disease treatment for the treatment of this paraneoplastic neurologic syndrome. So what are the rheumatological paraneoplastic syndrome we encountered in malignancy? These are most commonly seen our patient. One is hypertrophic pulmonary osteoarthropathy, which is the most common rheumatologic paraneoplastic syndrome, and it is most commonly seen in case of non-small cell lung cancer. Adenocarcinoma is the most common cause, and it is mediated by the vascular endothelial growth factor and platelet-derived growth factor. And inflammatory myopathy, it is clinical features same as dermatomyositis and polymyositis. It is most commonly seen in case of small cell cancer, and it is associated with anti-nuclear antibody and anti-Jo1 antibody. So of these two paraneoplastic syndrome, most common is hypertrophic pulmonary osteoarthropathy, which I am going to detailedly discuss in the next slide. So hypertrophic osteoarthropathy, it is also known as Pierre-Bamberger syndrome, and it is most commonly seen in case of lung cancer, and it can also be seen in cystic fibrosis and tuberculosis, but it is less frequently seen. And in all lung cancer, non-small cell lung cancer is more adenocarcinoma is the most common cause, but high incidence of hypertrophic osteoarthropathy is observed in solitary fibrous tumor of pleura, which is 22% versus the 5% of non-small cell lung cancer. And the mediators are the PDGF, VEGF, and prostaglandin E2. And the clinical feature we see in this hypertrophic osteoarthropathy, we can describe in A, B, C. One is arthritis and joint diffusion and pain. B is subperiosteal new bone formation, and C is the clubbing. So these three clinical features, patient with malignancy with new onset bone pain, we have to rule out this HOA. And in technetium leveled MTP bone scan, usually there is a characteristic tram-line or double stripe sign is seen, which is actually a parallel line of activity, new bone formation along the cortex shaft at the end of tibia, femur, and radii. So these are the this is the radiological sign we appreciate in the bone scans, bone scintigraphy actually. And the treatment for this HOA is the NSAID and octreotide and sometimes vagotomy, and are the alternate treatment apart from the treatment of the primary malignancy. So we have to remember this clinical feature of this HOA is arthritis, bone formation, and clubbing. So paraneoplastic dermatological syndrome, these are the manifestation we usually ignore, but this can straight away give us implication about the primary malignancy. One is paraneoplastic acanthosis nigricans, which is the most common dermatological manifestation in the non-small cell lung cancer, and it is caused due to the IGFR insulin-like growth factor receptor abnormality, and it is most commonly associated in the tribe term, which is acquired pachydermatoglyphia, so which is a velvety rugose thickening of the palm, and this these two entities usually seen as together in non-small cell lung cancer. And Reye syndrome is like acquired hypotrichosis lanuginosa, which is which I have shown in the image in the rightmost corner. So it is usually seen in case of colorectal cancer followed by the lung malignancy associated with fibroblast growth factor, and it usually characterized by the new lanugo-like hair formation in the non-hair part of the body, and it is most commonly seen in case of female. And second entity is the Bajek syndrome, which is also known as acrokeratosis, malignant acrokeratosis. Usually in this syndrome there will be nail dystrophy, both upper and upper limb and lower limb nail are involved, and it is most commonly associated with oropharyngeal malignancy followed by larynx, and in lung it is associated with 17% malignancy. And the etiology is not yet found. So another manifestation of the malignancy is like erythema gyratorum repens. It is characterized by the erythematous plaque all over the skin, along with skin thickening and drying, and it can manifest as erythema gyratorum repens, or sometimes it can lead to ichthyosis, and it is most commonly seen in lung malignancy followed by esophageal, and the least is the breast malignancy. So these are the clinical manifestation in the paraneoplastic manifestation of the lung malignancy. Thank you.